Hello and welcome to lecture 3. There's going to be some interesting stuff that we'll be covering this week, so let's get started. So one of the chapters, chapter 5, is covering systemic oppression, and there's several things that go into this. So ethnocentric monoculturalism, that's a really big word. It's basically known as cultural racism, and this is at the heart of systemic oppression. So there are a number of different factors that go into this. One is the belief in superiority of the dominant group. So think about, I think last week I talked about movie examples. So this is the idea that, the dominant group were more civilized, were more advanced. If you think historically, right, back to when Columbus came to America, for example, right, the American Indians were considered, you guys aren't very civilized. You live in these tents. Why don't you live indoors? That type of thing. Belief in inferiority of others. So this is the belief that, for example, certain facial features, certain lifestyles, for example, LGBTQ, certain skin complexions, etc., those types of things are all inferior. And then this also includes power to impose standards. So having a specific standard, but also having the ability to impose that standard onto others. So for example, a church or a religion imposing a standard that, the Bible says this regarding LGBTQ. So we're going to impose this specific standard based on a belief. Institutional racism, so this includes things such as policies, priorities, that type of thing that oppresses certain individuals or minority groups, and then perpetuates that unequal status and service. So status and services. So for example, think about our Constitution says that all men should be created equal. Okay, well, what about us women? Should we not be created equal as well? And so it's embedded, right, going back to language and how important language is as a part of culture. It's embedded in our language, it's embedded in our policies, which then results in that systemic oppression or the oppression continuing to occur over and over based on, our policies and institutional factors. This chapter also covers white fragility, which is when a response is triggered by racial stress, which can result from interruptions to what is racially familiar. There's several different examples in the textbook of that, so I'll let you guys read that there. And then, so the rest of the chapter 5 at least covers counselor credibility and really gets into trust, which I'll cover here in the next slide, and then we'll talk about locus of control and responsibility. So I really love Brene Brown's work. I think she's amazing and her research is really fascinating. So I wanted to talk about credibility, and this is covered in your textbook as well. Credibility has two components, expertness and trustworthiness. Both are important. I think trust is more important here, which is why I've got a couple slides on that. So let me talk about expertness here, and then we'll talk about trust next. So expertness includes factors like your education, your degrees, your certificates, your licenses, etc. Essentially, you knowing the information or having the expertise to help a client with their problem. So that's expertness, pretty straightforward. Trust gets into factors such as sincerity, openness, honesty, the client perceiving a lack of motivation for personal gain. So essentially, you as a therapist, I'm coming to see you because you don't gain anything from this. You're here purely to help me. Yeah, there's maybe some financial gain because you as a therapist are getting paid, but there's no other real motivation aside from the fact that you want to help this person. If a client begins to perceive that there's some type of personal gain or that you have some type of motivation to gain something from the situation or treating them, then that might decrease their trust in you, right? Because it's well, you're getting something from this. Your communication style also goes into building trust, right? Does the client feel heard? Do they feel understood? Do they feel like you're actually actively listening to them? If you're constantly interrupting the client or speaking over them, they're probably not going to feel heard, and that's going to impact trust. Trust includes self-disclosure. So how much will a client open up to you if they don't think that they can trust you or don't believe that you have their best interests at heart. They probably won't disclose that much to you, right? Or they might maybe not hide certain things, but they might not be as open and disclosing or forthcoming in terms of maybe their fears about certain things, or their worst thoughts or their worst nightmares, or whatever those things are. They might just fail to mention those things. So in this video, I'll put the link in the description, Brene Brown talks about how her daughter experienced trust in a school setting at school, and how her teacher had this like trust jar. So I'll talk a little bit more about the trust jar in the next slide. So trust, again, huge component of being a really effective therapist. And in the last video, Brene Brown, or the last slide video, Brene Brown talked about marbles in a jar. So what do marbles in a jar have to do with trust? Well, imagine that trust in each relationship in your life is represented by a marble jar. At its core, Brene Brown explains that trust is built in the micro moments, the seemingly insignificant moments of interaction. Relationships are built on trust. So if we want to be effective therapists, we need to make sure that we effectively know how to build trust with our clients so that they can depend on us, and so that they're willing to be more open and, take that leap of faith, if you will, towards giving therapy a chance and trying to get better, improve whatever the things are that they're coming to us to work on. So we can deposit marbles and build up our sense of trust, or withdraw them in our relationships, which then degrades the sense of trust through our interactions. So when someone is able to make more deposits than withdrawals from this marble jar, we trust them more, right? So for example, think about the relationships in your life. Who are the people that you trust? What have those individuals done to put the marbles into the jar? Or if you distrust someone or have less trust in that person, what has that person maybe done to take the marbles out of the jar so that you trust them less? How do people, essentially it's how do people show you that they're in your corner, that they have your back, that kind of thing. When my husband and I were dating, my mom ended up getting sick, and we'd been dating like maybe a year. So, he was like, hey, let's drive down there and visit her, that type of thing. That was trust, right? That's him putting marbles into that jar, because I felt like, okay, he really cares about me, or he really cares about the situation, even though he's never met my mom before. He's showing that he supports me, right? So putting trust into the jar, that was while we were dating. So you get the idea. So this could be a fun exercise either for yourself or to do with clients, in terms of thinking about and exploring what are the relationships that you have in your life, who are those people, and what have those people done to put marbles into the jar so that it's a really strong relationship. So based on the lectures so far, I've put in some discussion questions, which would be fun to discuss in class, in terms of, again, how do your relationships, how have you built those up? How do you interact maybe differently if you're interacting with coworkers versus peers versus colleagues? And is there that aspect of trust, either in terms of those relationships where you're putting marbles into someone's jar or someone else is putting marbles into your jar? In terms of working with clients, how would you handle someone asking about your credibility, in terms of, hey, I'm coming to you as a therapist, are you really going to be able to help me with this problem? Or what are your, what are your credentials? What is your license? What is your degree? Because I've had clients ask me all of those things. Do you think within therapy relationships, how do we convey trustworthiness? How do we convey that expertness? What would we communicate to clients so that we're putting them at ease? What do you think that conversation would look like? So we're going to switch gears here a little bit and talk about locus of control. And this is where we want to consider the client's perspective. And of course, there's going to be kind of this range, if you will, or different perspectives or worldviews, which we've talked about. There's the Western view, and then there are other views, such as, this idea of don't rock the boat, or there's nothing that I can do about it. And so paying attention to those different factors when we talk about locus of control is, of course, important. Within locus of control, there's kind of these two sides of it. One is an internal locus of control. So what are the things that I can control? What are the things that are internal to me in terms of like my thoughts, my physiological response to something, like am I sweating more, that type of thing. And then there are the things that are external to me. What are the things that I can't control? So essentially, what's within my control, what's outside of my control. And when we talk about locus of control, we talk about, when working with clients, does this client have this view or this approach of an internal locus of control? Do they view or do they believe that they can control their actions, their decisions, how they engage in life, what they do in life? Or do they have more of a passive or external locus of control of things happen to me, life happens to me, I don't decide my fate, I have no control over what my life looks like. Individuals who have an internal locus of control in terms of therapy and working towards things, oftentimes, because they have that approach, I don't want to make any generalizations here. There's maybe more action that is taken because they have this belief or this view of I can control what happens to me. I am, the maker of my fate, if you will. Whereas, if a client is like, well, this happened to me or that happened to me, or I have no control over anything, it becomes very easy to almost kind of get into this funk of, life just keeps happening to me and I can't do anything to fix it. So like, what's the point of even trying almost? Here's another example of locus of control. And this is also getting into locus of responsibility, which is very similar. So does the person take responsibility for something or not? And this one we kind of want to be careful with. If clients have experienced years and years of systemic oppression, it's not going to be helpful to tell them to do something like just get over it or just move on, because that's being very dismissive, right? One of their feelings or emotions or thoughts, but also very dismissive of how the system has played into essentially helping create who that person is or who that person has become. So for example, the textbook mentions Latino Americans and their standard of living may be lower, right? Lower socioeconomic status, which could be due to, if you, going back a couple slides where we talked about inferiority, if you view it as a personal shortcoming, if you say something like, oh, Latino Americans are lazy, you're placing that blame or that responsibility on the person, as opposed to thinking about, well, what about the racial discrimination or the oppression that maybe has occurred in this person's life? Latino Americans potentially have experienced a lack of opportunities, for example, right? And what about that systemic oppression or those systemic factors are impacting this person? And so in terms of responsibility, we want to be really careful not to blame the person, but to blame the system that they're in. Because if a system is putting up barriers or preventing someone from being able to move ahead in life, that's something that we really want to be careful that we're not then blaming that person. But in terms of responsibility, again, this is that side of, is the person taking responsibility for their actions, or is it, oh, life is just happening to me, there's nothing I can do about it, I'm not going to take responsibility for my actions. What's a good example of this? For example, it would be something like, if someone gets a speeding ticket, do they take responsibility for that speeding ticket and pay it? Or do they say, oh, it wasn't my fault, I was running late trying to get my kids to school, and I didn't even see a posted sign of what the speed limit was, so it's not my fault, I'm not going to pay that ticket. And then that becomes an even bigger issue, right? Because if you don't pay a ticket, those tickets start to pile up, et cetera, et cetera. So yeah, that's a little bit about locus of control and locus of responsibility. I like using worksheets with clients because sometimes seeing something on paper can make it more real, and a lot of times it can be helpful to give them homework to do between sessions. So this is something that you guys could use with your therapy clients, and this will be the part of your discussion post this week, is exploring what are the things that are inside of your control, outside of your control, And again, this can be really helpful because a lot of times clients will, especially if there's anxiety going on, focus on the things outside of their control and be worrying about those things where it's like you literally have no control over that, right? If it's snowing and the roads are icy, you can't control the weather. And so helping clients increase their awareness around this can be helpful, because then it's like, oh, you're spending all of this energy and effort focused on things that you can literally do nothing about. So this is part of your discussion post, which you'll see here in a slide or two. So a couple questions, right? You guys probably at this point are like, wow, you really love discussion questions. So powerlessness is defined as the expectancy that a person's behavior can't determine the outcome or reinforcements that he or she seeks. So this would be a fun point in time to discuss significant power differences and how you think those might play out in a therapeutic relationship. Have you experienced, if you've gone to therapy, have you experienced a power differential in a therapeutic relationship? And what has your experience of that been? Or if you've never been in therapy, think about just what have been the power differentials that you've maybe experienced in other situations. For example, with your supervisor or your boss, or with a teacher at school, or something or even with your parents or caregivers. And starting to notice your increased awareness around what do those power differentials look like? How do they play out? And within the therapeutic room, at least, how do we pay attention to that power balance? Because a huge part of therapy is, especially within systemic oppression and some of the things that we've talked about, exploring how do we help our clients advocate for themselves, realize that they can advocate for themselves, and essentially kind of put the ball in their court, or like give them the power back, or help them realize that they have the power to take control of their lives. So I like saying, like, put the ball back in your court, or have the ball in your court, to be able to then say, okay, I have control over this. What decisions am I going to make to improve my life, to reach my goals, to, deal with whatever the things are that has brought the client to your doorstep to begin with. So anyways, yeah, some fun questions to explore there. So chapter 7, switching gears here a little bit, racial and ethnic minorities have less access to mental health services than do whites, and are less likely to receive needed care and more likely to perceive poor care quality when they do get treatment. Minorities in the United States are more likely than whites to delay or fail to seek mental health treatment completely, so they might not even go. And after entering care, minority patients are less likely than whites to receive the best available treatment for depression, anxiety, etc. And again, this kind of gets into that systemic oppression side of things, just in the sense of, I think I talked about this in a previous lecture, right? Who used to go to therapy, or who used to be able to have access to therapy, would be middle class or up, right? Because therapy used to be, and still is to some extent, very expensive. And so realistically, most people don't have the money to pay that amount weekly or even bi-weekly for therapy. And here's a couple statistics. Among adults with diagnosed mental health concerns or substance abuse issues, 37% of whites receive treatment, but only 22% of Latinos and 25% of African Americans receive treatment. So you definitely notice some disparity and differences in those percentages. Chapter 7, here are some of the things that the textbook covers and that I'll be talking about. Self-disclosure, that'll be a research article at the end. It's not specifically multicultural based, but just talks about disclosure in general, which kind of goes back to that trust slide that we talked about earlier. So I thought it would be interesting to incorporate that. So addressing model, this was developed by Hayes. He's written a whole book about it. It's an interesting way or model to think about diversity, and addressing is a nice word to help us remember, either as we're going through therapy or as we're talking to a client, to be thinking about, does this client meet some of these factors or not? You can read the slide there, pretty straightforward, most of these things. Socioeconomic status, I've talked about that. Is the client poor, middle class, upper class, etc., 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 etc. I don't know if this is hard to read or easy to read in terms of the screenshot there, but hopefully it's not too difficult to read. It is from the Hayes textbook and is just an example from a case of how to apply the Hayes model or the addressing model to a sample client. So this is something else that is your homework, just a fun little exercise to apply the addressing model to yourself and look at how does this break down for you specifically. Oh, and here's the discussion post. Okay, so I think the worksheet should be in Canvas, and if not, it's going to be in the slide that you saw in terms of that locus of control exercise. And then you've got the addressing exercise. So 2 exercises this week, trying to break it up a little bit instead of just consistently asking questions. And again, these 2 exercises are both focused on you, right? So I talked a little bit in a previous lecture about kind of trying to balance this class in terms of self-exploration and learning who we are, but then also keeping the client in mind as well. So this week focused on us. So this research was done in Tel Aviv at Tel Aviv University, which is in Israel. It was done by Ziv Beeman and colleagues in 2017. So it's a couple years old at this point. But I thought it was interesting, again, because it looks at self-disclosure in therapy. And self-disclosure is one of those things that it can be really easy to do if we're not being very intentional or aware of ourselves and thinking about it. So therapist self-disclosure, essentially it's when we say something in terms of our own internal thoughts or share something about ourselves with our client. And there's several different forms about it, several different forms of self-disclosure. I'll talk about that here in a minute. So therapist self-disclosure contributes to patient perception of the therapist as warmer, more attractive, particularly when the information divulged resembles the client's own experiences. So for example, if the client, if you as a therapist say something like, I've been through a breakup before, that really sucks. That's you divulging that information that's similar to the client's experience, which can make the client view you as the therapist as this is saying warmer, more attractive, etc. At the same time, though, disclosing therapists tend to be perceived as less professional. So depending on how you divulge that information, you might be considered by the client as less professional. Disclosures relating to similarities between the therapist and patient were found to deepen the patient's self-exploration and exert a normalizing effect. So it helps the client normalize their situation and say, oh, okay, I'm not the only person in the world who's ever experienced this. Frequent disclosures, on the other hand, so if you're constantly talking about yourself or sharing your own experiences in therapy, that can be that in this research at least found that too much of it ended up harming the therapeutic relationship because essentially the client feels like, why are you talking about yourself? Is this your therapy or my therapy? So too frequent of self-disclosure makes the client or the patient feel like it's displacing the focus of therapy from the client onto the therapist. So 86 patients or clients were involved, 22 therapists, and then the procedures were they did informed consent, they gathered data, they did an intervention, and then it was divided into 12 sessions. Divided from there into 12 session conditions. So the data gathered, this is a brief symptom inventory. So essentially looking at psychiatric symptoms. So what types of symptoms was the client saying that they were experiencing in terms of like anxiety, depression, that type of thing. After session, so they did a final, after the final session, they gathered a little bit more information in terms of again, looking at what kinds of symptoms the client was experiencing. And then they did a 4-item questionnaire evaluating the therapist's professionalism, pleasantness, treatment efficacy, and helpfulness. And after termination, therapists were also required to assess their own professionalism, pleasantness, and efficacy. So a little self-reflection going on in this research article. or research study. In terms of exclusion criteria, so any clients who had a history of suicidality or psychosis or acute need for crisis intervention were excluded from the study. They didn't involve those individuals. And because the research was done in Israel, individuals needed to be able to speak the Hebrew language, and they looked at individuals who are only 20 years and older. Limitations. So there's a couple different limitations in this research article. One is the sample size. 86 people is not very many people. You would definitely want more when looking at or doing research. They didn't use the gold standard procedures for identifying psychiatric diagnosis. So a gold standard would be a structured clinical interview. Patient self-report measures might not be accurate, right? Because there's a bias. And so especially if people know what you're looking for, they might intentionally or unintentionally bias themselves and respond a certain way. Future research. So there's always room for growth. There's always more that we could do in terms of research. So the study didn't look at what's known as positive and negative self-disclosures, which might be interesting to include or look at in future studies or research. So I talked a little bit at the beginning. I said I'll explore or discuss different types of self-disclosure. So there's an immediate self-disclosure, which is expressing feelings towards the patient, towards treatment, towards the therapeutic relationship. And this pertains to the articulation of the therapist's feelings towards one of those things, patient, treatment, or therapeutic relationship. For example, a therapist might say, "I've been thinking about your incredible efforts to support your family during these hard days, and I really admire you for that." So that's the therapist sharing how they view how their view of the patient. "I admire you for how you're handling it." Another example would be, "In the past few sessions, I've experienced you as much more reserved and detached than usual." So again, it's us as the therapist in this example, sharing their perception of the client over the last couple of sessions. I've experienced you as more reserved. There's non-immediate self-disclosure. So this is expressing more personal or factual information regarding the therapist's life outside of treatment. And so that would be something like, "I also procrastinate, but I've discovered that every time I manage to find a way not to do it, I'm really proud of myself." So you're sharing something that you've struggled with. "I also procrastinate," in regards to or in relation to, working with that client and how they might be experiencing procrastination. Another example is, "I know from previous experience that a romantic breakup is enormously painful." So again, sharing something from your past as a therapist as applied to that client's experience. And then the results. So the results showed that among symptomatic patients, integrative psychotherapy augmented by immediate therapist self-disclosure alleviated psychiatric symptoms more than integrative psychotherapy with either non-immediate self-disclosure or no self-disclosure. Secondly, they found that in an integrative psychotherapy augmented by immediate therapist self-disclosure, both patients and therapists perceive the therapist more favorably than those in the non-self-disclosure treatment group. And finally, therapists, but not patients, in the non-immediate self-disclosure condition evaluated themselves more favorably than their counterparts in the non-self-disclosure condition. So what are the implications? Why would we as therapists care about this? Well, as I mentioned, and as you probably saw in the examples, self-disclosure is something that's really easy to do as you're having a conversation with somebody, like, "Oh, my perception of you today is that you're more happy than usual. What's going on?" Right? Like that right there is a self-disclosure. And it can be really easy to do that. So paying attention to what types of disclosures we're doing, and is that always keeping the client at the forefront? Is this self-disclosure going to be helpful for them and beneficial to therapy overall, or is it going to in some way be harmful? So that's why it's important for us as therapists to know this information and pay attention to it, because it also impacts the patient's perception of us and the therapeutic relationship and trust and all of those things that we've talked about over the course of this class specifically. So that's self-disclosure in therapy and a little bit of research. And here's my reference. Please let me know if you guys have any questions, comments, or concerns. Thank you.